Welcome. I am Erin Trish. I'm the Associate Director of the USC Schaeffer Center, and we're thrilled to have you join us today. Thank you for attending. This is the first of our two-part webinar series entitled COVID-19 Changed Healthcare Decision-Making. What does it mean for the US healthcare system? Today, our panel will focus on the impact of the pandemic on healthcare, including how the pandemic has changed patient preferences for healthcare. And we'll feature a discussion with a number of distinguished participants, and we'll talk about whether we expect these trends to continue post-pandemic and what do they mean for long-term care and costs. In terms of logistics for today, I'm going to start off with a brief presentation just to kind of orient everyone to what we've seen over the last year in terms of healthcare utilization. And then I will introduce our panelists and we'll feature a discussion among all of these folks, including the opportunity to answer questions from you. So audience members can submit their questions at any time using the Q&A feature at the bottom of the screen. So the impact of COVID-19 on healthcare utilization, what have we seen? So perhaps if we had been having this talk about a year ago, this would have been a webinar focused on how much we spend on healthcare in the US, right? About 18% of GDP, or about $2.3 trillion spent on healthcare in the fourth quarter of 2019. But then the pandemic happened, and what did we see? Well, a dramatic reduction actually in healthcare spending in the US to the tune of about $500 billion. So that equates to about $1,500 per person on average across the entire US population in reduced healthcare expenditures in that quarter alone. Now, what we've seen since then is that there has been somewhat of an increase, but still we're not even back at a return to the kind of pre-pandemic trends. And the discussion today is about, well, what was missed during that time and what does the impact of that mean for the healthcare, for our patients, for our providers, and for the healthcare system moving forward? So what did we miss during that time? Well, research by Chris Whaley at RAND and Neeraj Sood at the Schaeffer Center and other co-authors looked into this in the commercially insured population. And what they found is that for the first several months of the pandemic, there was a dramatic reduction, particularly in the use of elective care among patients in these first few months. Now, part of that was likely driven by public health regulations or provider capacity decisions that chose to kind of postpone or defer some of this care. And some of that was likely driven by patients' fears of not wanting to go out in the uncertainty of this pandemic and not wanting to expose themselves to catching this virus. But what we'll talk about today is the experience of the panelists and whether this is what they saw in their patient or provider experiences, but also what this means for these patients moving forward and what's the potential impact, both short and long term, of this missed or deferred elective care. We also saw other Schaeffer Center research focused on the use of emergency room services during the first few months of the pandemic and saw also a dramatic reduction in the use of a large emergency room in LA County as well. The one other kind of key change that we've seen in this time is a dramatic uptick in the use of telemedicine visits. And so these telemedicine visits went from less than 1% of visits across the US healthcare system to a dramatic increase, basically going from almost nothing to what's now sustaining at more than 10% of visits today. So these telemedicine visits were a rapid response and kind of a pretty impressive showing of the nimbleness that the healthcare system could achieve when needing to respond to these to the environment of the pandemic. Didn't quite offset all of the visits that were canceled, but certainly reflected a dramatic transition in the provision of patient care services. And one of the other key questions that we'll think about or discuss today is what might be the lasting impact of this, right? To what extent was this driven by just kind of need and necessity and some reimbursement changes? But now do patients and providers like it? And is this here to stay? And what does that mean for patient care as well? So with that, I'll conclude the kind of brief overview of what we've seen in terms of healthcare trends. And let me start by introducing our panelists. We're joined today by Dr. Suzanne Barron, who's the Director of Interventional Cardiology Research at Lahey Hospital and Medical Center, where she practices as an interventional cardiologist. She also has research interests in value-based care and focuses on evaluating the effects of novel cardiovascular devices on patient-reported outcomes and healthcare costs. We're also joined today by Dr. Otis Brawley, who's a Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins University. He is a board certified medical oncologist and epidemiologist, and also an authority on cancer screening and prevention. We are also joined today by Dr. Wendy Bruin de Bruin, who is the co-director of the Behavioral Sciences program at the USC Schaeffer Center. She's also a provost professor of public policy, psychology, and behavioral science at USC. And her research focuses on understanding and informing how people make healthcare decisions. And she's been leading one of our national surveys focused on Americans' COVID-19 risk perceptions and protective behaviors over the last year. Finally, last but not least, we're joined by Dr. Emmett Keeler, who is the non-resident senior fellow and quality assurance director at the USC Schaeffer Center, and also a professor at the Pardee Rand Graduate School and adjunct professor at UCLA Public Health School. He is an elected member of the IOM and has had a distinguished research career focused on healthcare and health insurance. And we're fortunate today to have Dr. Keeler join us as a patient, providing his perspective on using the healthcare system over the last year. So with that, let's kick it off with a question to Suzanne. So we saw in the charts that we looked at here, as well as just the broader literature, that in the initial surge or the spring of 2020, there was a dramatic reduction in patients showing up at the hospital with heart attacks and with strokes. So I'm curious from your perspective if this is what you saw at your facility and what that meant for care and whether things have returned to normal since then.
Absolutely. So we definitely saw that at our facility. I'm up in the Boston area, and we were hit pretty hard by the initial surge. Things shut down here towards the end of March, beginning of April. We shut down for all of elective procedures in the cath lab, and things that were continued were things that were either urgent or emergencies. I think one of the interesting things is acute heart attacks. So folks coming in needing care in the middle of the night. Those numbers dropped by almost 40%. And the interesting thing there is I certainly wouldn't think that this is because patients weren't having these heart attacks, but I think was probably driven, at least in part, by patients' fear of coming to the hospital. And so we did end up seeing patients showing up later on saying, hey, I had symptoms about a week ago, and I've just been feeling really lousy since, and coming and saying, well, gee, about a week ago, we think you had a heart attack. In response to this, certainly the AHA, the American Heart Association, and the American College of Cardiology, and some of the other societies really did try to do a public health push to encourage our patients that if you have symptoms, please come to the hospital. We will work to keep you safe from the virus while you're here, but we want to make sure we take care of any emergencies that you have, your heart, brain for strokes, and things like that.
Emmett, you were scheduled for hip replacement in March. So can you tell us a little about how that went from your perspective and how that played out?
It's similar to what you were showing in your charts. At the start of last year, it hurt me to walk. So after some diagnosis, I was scheduled for a hip replacement. And I went to a guy, Dr. Andrew Young, who has a factory that runs these operations. And he had a protocol that was very strict. And we went in there in February, and he handed me a 40-page book about what was going to happen. And what was going to happen was they would do the operation, and then you'd stay overnight, and they'd give you a lot of physical therapy and self-care instruction and so forth. So the operation was scheduled for early March, and then called off. St. John's called off all of their elective procedures. And subsequently in May, they decided that they would redo the procedure as an outpatient experience, and only healthy patients were going to get it. Well, I'm not a healthy patient, but I don't know whether they stretched it for everybody, but they stretched it for me. And I went in there, and as it turned out, I didn't leave on the same day that I did, but a lot of the things that were in this 40-page book about what was going to happen in the hospital actually happened in my house later. So a physical therapist came to the house, a nurse came to the house. My poor wife had to struggle with a catheter. I had some trouble peeing, and it's not obvious to lay people how to do this stuff. But, we did it, and she was certainly happy when that ended. One funny thing that happened was I was discharged on the day of the big George Floyd protests in Santa Monica. and I was supposed to pick up some meds. And as we got to the grocery store, there was a tremendous stuff going on there. All the local pharmacies were looted. So all the pharmacies were closed and looted. We never got medicine. But, you know, all in all, the physical therapists that came to the house, the nurses that came to the house, they were fine. It was just that a lot of stuff that formerly would have been done in the hospital was done in my house, and the operation had to be postponed for 2 months. But other than that, I thought it went pretty well.
Wow. So it sounds like we have some honorary clinicians to award at the end of this pandemic. So Otis, we've heard now some stories about the kind of impact of care or the changes in the care that's occurred, but thinking back to the charts that we were looking at, there were a lot of delayed foregone screening as well. And you've kind of made your claim to fame in this environment, right, about the impact of overscreening or certain populations. So can you tell us a bit about what you think might be the impact of some of these kind of delayed or foregone care, or what we might expect to see this play out in terms of patient health?
Yeah, it's important to remember in March, the federal government literally told hospitals, stop treating other than non-urgent people. And so a large number of people did not get treated. There were people who had diagnosed breast cancer and colon cancer who had their treatments delayed during that period of time. Now, the National Cancer Institute has done some mathematical modeling, and they think that by 2030, it's going to cost us about 10,000 deaths from breast cancer, about 10,000 deaths from colon cancer. That's delay in treatment of diagnosed disease. Now, the screening thing, I'm one of the people who thinks that screening is hyped more than it deserves. You know, the best mammography study that's ever been published did mammography for women every 3 years. The best outcomes. The best colon cancer data we have is that colonoscopy should be done every 10 years. I'm a believer that if people miss their colon cancer screening or their breast cancer screening by 6 months or 9 months, it's not really going to be a big deal in terms of statistics. You know, there will be some people diagnosed with metastatic disease. They probably were going to be diagnosed with metastatic disease anyway. I do encourage people to get back into screening as soon as possible. And we're pretty much at Hopkins, we're pretty much back to normal. We're running 95 to 100% capacity right now.
Wendy, thinking about this concept of kind of getting patients to re-engage with the healthcare system, I know you've done a lot of work thinking about or focused on understanding patients' perceptions of risk. And can you comment on, what you think it's going to take to get patients to come back, and if you think that there'll be differences across different patient groups and how you might see that play out from their perspective?
Yeah, so with the Center for Economic and Social Research at USC, we've been running this Understanding America study where we've been tracking people's experiences with the pandemic since March 2020. So it's been running for more than a year. And so one of the things that we're currently tracking is who's getting vaccinated. And I think we're not the only source that's reporting that it's especially white, more affluent people who are disproportionately getting vaccinated. And in communities of color, especially in LA, but possibly also other places, the vaccination rates are lower because of various reasons, but it's not that easy to get an appointment. You have to fight with a website. You have to go to a location that may not be near you and go at a time that may not be convenient to you. You may be maybe in the middle of your workday. So there are various barriers to getting vaccinated. And so we're seeing that in communities of color, vaccination rates are relatively lower. But these are also the communities where risk perceptions have tended to be higher. So people may be more hesitant to return to their doctors if they're not vaccinated. And so disproportionately white affluent people may be returning to their doctors, but people from communities of color may not feel happy to do so quite yet. and so they may be missing out on important care.
I think I've absolutely seen some of that. Certainly folks in my practice, at least who have been vaccinated, have been coming back to the office wanting to be seen in person. And I've certainly had patients who have said, hey, yes, can I get my echocardiogram, my ultrasound of my heart, or can I get my cardiac catheterization in a couple of weeks after my second dose of the vaccine, because I just want to make sure that I'm covered. And so I think really I think we are going to see those disparities coming out even more because of the fact that there are differences in the communities that are being vaccinated. And I think that's a really important point.
Otis, I'm curious, as running an oncology practice, do you believe that the vaccines work kind of equally well for patients with chronic conditions? And are you concerned about, or do you have thoughts on how this might impact your patient population in particular?
Well, by and large, I recommend everybody get the coronavirus vaccine. There are going to be some people who have B-cell malignancies or B-cell diseases, some people who might have some of the immune diseases like rheumatoid arthritis, where we're not sure that the vaccine is going to work as well. And that's even more reason that we need to think about the concept of herd immunity, trying to get 70 to 80% of the population who are immune so that we can protect those who the vaccine won't work in, or the people who simply can't get the vaccine. And that's another important point. There are going to be a small number of people who get the vaccine and they're not going to have neutralizing antibody from the vaccine. Their B cells just won't work. There's a failure in almost every vaccine that we have. The coronavirus vaccine should be no different.
So in thinking about this too, I mean, part of this is a, hope that we may be able to return to some, sense of normalcy in our both everyday lives and in our healthcare utilization. But I think, it's a good kind of never let a good crisis go to waste type of moment as well. And we've seen these changes in the form of telemedicine. And I'm curious, so, Emmett, for example, have you engaged in telemedicine, and do you think that these experiences will kind of change your interest or your hopes and dreams from the healthcare system moving forward?
Well, when in March, when the big surge started, I teach decision theory. So I calculated what my chances of dying were if I got COVID. And because of my age and everything, it's 25%. Now that's a big number. I mean, that's bad news. So I decided I would not get any kind of chronic routine care face-to-face. And I had one telemedicine visit, but I didn't like it very much. And so what I've done is I got my second shot on March the 1st, and I've just been bombarding doctors and dentists and everything else, catching up on the routine care for a year, and I think it's okay. My dental hygienist yelled at me, but the doctors were nice, because there's nothing like plaque that builds up. Well, maybe there is on your heart, but anyway, I think a lot of people must have done that. I didn't like telemedicine. I had to teach a Zoom class in the fall, and I hated it because you got no feedback from the students about what was going on. It just wasn't fun, and I wasn't anywhere near as good. And that's got to be true for the doctors. I mean, they say, "How are you doing?" You say, "Okay." They say, "That's great," and that's a telemedicine visit. And it's much better to be in their presence and them touching you and looking you in the face and so forth. So I'm not. Telemedicine must be necessary in many cases, but I'm happy to go back to face-to-face medicine.
Interesting. So Suzanne, is that from a provider's perspective, can you talk about your experience with telemedicine and how it shaped you in both positive and negative ways, your interactions?
Yeah, I mean, I think as you mentioned initially, it was a really great example of how the medical community kind of adapted very, very quickly to a pandemic that, we've never seen, well, we haven't seen since 1918 in that way. And so having telehealth here as an opportunity to kind of grow and expand and to offer care for folks, when we had to offer something was good. That said, I agree with Emmett. I think that there is something that's very important and tangible about a face-to-face doctor-patient relation. And certainly if a patient says to me over telehealth, like, well, gee, I've been feeling more short of breath. Well, it's, I'm going to want to take a listen to their lungs. I'm going to want to take a listen to their heart. I'm going to want to look to see if they have any swelling in their legs. And that's stuff that unfortunately can't be done over telehealth. That said, again, I do think it allows us an opportunity for us to have more regular contact with our patients for things like follow-up. Let's say I start a patient on a new blood pressure medication and, they're monitoring their blood pressure at home. I can set up a 15-minute follow-up call to say, hey, are you tolerating it? Are there any, are you having any side effects? What have your blood pressure been? Let's see if we need to change the dose. And I think certainly from just an ease of having patients have to come in and out of the hospital, cancel work, get a ride, et cetera. In those situations, I think there absolutely will be a role for that. We have, at least at my institution, we are transitioning back to being mostly office-based. All of our new patients are now being seen in the office, and many of our established patients are as well, with the idea that we will be transitioning back primarily to an office-based practice.
Interesting. So, I think I'll admit that as a patient who had my first telemedicine visit during the COVID pandemic, I was a little suspect at first, but it was quite convenient to just sit right here and not worry about parking and not worry about traffic or any of these things. So Wendy, I'm curious if you have any thoughts on how this is playing out from a patient perspective or preferences lens.
Yeah, even before the pandemic, there was research on patient preferences for telehealth. And the findings are sort of in line with what you say. So the patients who like it are the ones who find it more convenient, who are very busy, who have to sit in traffic otherwise because they live far away. I think that that during the pandemic, more people have now been exposed to telehealth, and some of them might like it and want to continue it. And then the kinds of appointments that patients, even the previous research on patient preferences for telehealth suggested that it's exactly the kind of appointments that Suzanne said she would like to, and thought telehealth was relatively good for. So follow up on refills or check-ins that do not require face-to-face contact. I must say that even at USC, from what I understand, some of our master's students have liked getting their classes online, especially in master's programs where students have full-time jobs and are doing these classes in the evening where they would have to sit in traffic to get between their job and the campus. So even for students, we're finding that some of them actually might like getting more Zoom classes.
Interesting. So I'm curious also, we're starting to get some great questions, and I want to remind the audience that they can submit questions through the Q&A feature. But some of the questions that we've gotten so far are about kind of what's the potential impact should we expect a return or this kind of pent up demand coming back and seeing increased utilization later after the fact? Is that just going to be a kind of catch up on care that would have happened previously, or are we going to actually see long-term ramifications of this missed or delayed care? So Otis, I'm curious if you have any thoughts about what we've learned from previous pandemics.
Yeah, I think we are going to have some pent-up demand, and then there's going to be some long-term problems. In the case of, say, mammography, the lines are getting longer and longer of people waiting. I don't think there's going to be a long-term harm, but there's going to be, if you want to get a mammogram right now in Baltimore, the wait is much longer than it would have been in, say, March of 2019. And so that's going to be a problem. I think that one thing that hasn't been focused on enough is what are the long-term consequences of having COVID. We don't know that yet. And I would point out that it was 1953 that a paper started to be published showing a correlation between Parkinson's disease and having what we now know as the H1N1 influenza of 1918, 1919. It was 30 plus years later that they brought that correlation. I am very worried about the effects on the lung of people who've had COVID pneumonia. I'm worried about long-term problems in the immune system. It may even be linked to some malignancies in the future. We don't know yet. So for young people who are saying, if I get COVID, I'm only inconvenienced for about a week or two, I try to avoid COVID because you may regret that when you're 50 years old.
Sounds like good advice. So I'm curious also, Suzanne, are you seeing as a result of this shift in, for example, you were describing that certain types of procedures where patients could get out of the hospital more quickly were permitted to go forward, while longer stay procedures might be canceled or deferred. Do you see this as a kind of shift toward a different type of healthcare in the future where we try to focus on some of these more minimally invasive types of procedures or techniques?
I do. So in my center, when we do cardiac catheterization, our default is actually for same-day discharge. So a patient will come in, they'll get their cardiac cath. If everything goes, to plan, we generally send them home the same day. That's not necessarily standard everywhere. A lot of places do keep patients overnight. In speaking to some of my colleagues at other programs who didn't have a same-day discharge protocol in place, once the COVID pandemic hit, that type of protocol was instituted at some of these other places. And I expect that that's something that's here to stay. If we can do it safely and allow patients to be home, just like Emmett was, I think that's how we'll certainly be trying to push for that. As far as other procedures, some of the procedures I do are minimally invasive valve replacements. As compared to open heart surgery. Some of the minimally invasive valve replacements or something called TAVR is something that, again, we have patients that can go home the next day after that. Patients tend to prefer that procedure, particularly for the shorter recovery period. But, we may, in general, but we may also be seeing a little bit more of a push for that as well, given the fact that, again, we can put protocols in place to get patients home safely the next day.
Interesting. Wendy, are you seeing anything out of has the tracking survey been following any kind of evolution of patients' perspectives or preferences, or even if not just in healthcare, but in general, this kind of shift to the Amazon nature of everything, right? Getting delivered to us, or kind of a shift in our expectations of how we want the world to work in the future?
I don't think we have questions about telemedicine per se, but yeah, people. I think a lot of people are working from home, those who can, and getting food delivered. And so, yes, this may be a convenience, and many other things delivered. And so that may be a convenience that people want to continue after the pandemic. But I think a lot of us are also just eager to return to restaurants and shopping in person.
Absolutely. So Emmett, would you prefer to have, if you were to have another surgery scheduled, would you want to do your recovery at home again? Did you prefer that, or did you have any reflections on that?
There's a difference of opinion. I actually liked it at home. My wife wanted me to stay in the hospital, not eager to be doing all the nursing work. My daughter's a nurse, and in another situation, she would have come down from Seattle to take care of me. But of course, that couldn't happen either. So the number of community supports that people rely on also went away somewhat during the pandemic. But, I think, it's all going to snap back after the surge of demand goes through. I don't see why people are going to be afraid to go to the doctor's office or afraid to go to a hospital anymore than they were in 2019. I think it's just going to wash through. I don't know when that'll start, maybe not till the fall. But, every day is great because every day you get to do something new that you haven't been able to do for a year. Golf, tennis, whatever. I mean, life is just getting better, and that's good.
Aaron, I've been taught that the hospital is not a great place for people to be in terms of infectious disease. I'd be interested in knowing what Dr. Barron thinks of that. I've always tried to minimize my patient's stay in the hospital because we have these things called nosocomial infections, and that's a big word, but it's a bad thing. You know, I even treat community acquired pneumonia differently from hospital-acquired pneumonia. I don't know what Dr. Barron thinks of that.
I completely agree with you. You know, I've been taught the same thing. We want patients to stay in the hospital for as long as they need to, but not a day longer, because patients can be at risk for developing infections with all sorts of nasty bugs that, you know, you don't get in the community, you only get in the hospital. And also, I mean, we certainly see patients who, you know, get more confused when they're in the hospital for a long period of time, and that can slow recovery. Patients get more deconditioned despite our best efforts at getting folks up and out of bed. And so I absolutely agree with you. I think, if anything, I'd like to think that the COVID pandemic has helped us a little bit in trying to maybe, you know, develop more of these protocols to get patients home safely with the appropriate support networks that they need. And whether that's home nursing, PT, physical therapy, occupational therapy, to make sure that they can recover safely at home in their own environment.
Yeah, I think the appropriate supports may have broken down in some instances during the COVID epidemic, but keeping people out of the hospital, I think, is here to stay.
Yeah, agree.
And I'll give a plug. We're getting a couple of questions on the sort of impact from the reimbursement perspective and thinking about how we need to evolve as payers and as kind of care delivery systems. And much of that will be the focus of the panel tomorrow. But I am curious from your perspective, if this is shaping kind of any of the, you know, are there payment policies or kind of other barriers in place that you see needing to change to foresee this transition, or kind of what can the system do to help facilitate some of these changes that we need to see?
Well, I'm not an expert on billing and how things are paid for. I will tell you that I sense that, you know, most hospitals that I know tighten their belts and actually expected to take a huge hit during this period of time. I'm not sure if that has happened or not. And then there's also the problem with COVID, and, you know, our hospitals were overrun with people who had coronavirus, and I don't know how that is going to be reimbursed. I can tell you that my friends who actually run hospitals are all telling me that every hospital right now is in some financial concern, if not dire straits.
Yeah, I share essentially your opinion on that. I think certainly from an inpatient perspective, I think that, you know, working on getting patients home sooner, out of the hospital quicker, I don't think that that's going to be per se a huge impact on reimbursement. That said, you know, telehealth, you know, initially was reimbursed and at the same rate as an inpatient office visit. And I think that at least in where I'm working now, that has changed, and telehealth is reimbursed at a lower rate. And so I think from a financial standpoint, it will be important, if we want telehealth to stay, that, you know, we consider what are the ramifications of having a telehealth and an office visit reimbursed differently.
And I think just much of that will be part of the focus of the discussion tomorrow as well, and thinking about how kind of the both from the payer side and the kind of broader delivery system perspective, how we can kind of evolve the way that we think about value from the healthcare system as well. But one more question related to this, Otis, I'm curious, you know, being based also in a school of medicine, are you seeing any impact on kind of interest in those applying to med school or other types of, what's the impact this is having on the workforce or the future workforce?
Yeah, now I tell you, some people are referring to it as a Fauci effect, but applications to medical school this year are at probably a 25 to 30-year high. This is not a good year to apply to medical school because there's so many people applying to medical school. And I also, you know, I stand in the School of Medicine and the School of Public Health. we've had a doubling of applications to graduate school in public health as well. Now that here at Hopkins, I'm not sure if that's due to an interest in epidemics and public health, or if that's because of the Johns Hopkins dashboard that's keeping the count of how many people have developed coronavirus and died from coronavirus. But we're seeing a lot. The people who work in the admissions office at every medical school in the country have more work this year than they've ever had in their career. And in the School of Public Health at Hopkins, they're also quite busy in the admissions office.
If I can add, the USC psychology department also had a large increase in applications. So there may also be an effect of the pandemic in general. I don't know other departments at USC if they had the same increase, but psychology did.
Well, I tell you, I'm very concerned about mental health after the pandemic. We may need more psychologists.
That's true. Yeah. I mean, even right now during the pandemic, it's difficult, especially for younger people and families with young children, people who have lost their jobs.
Well, along that line, actually, one of my friends, the match just happened for medical students who are matching to their residency and their postgraduate training. And one of my friends actually told me that psychiatry was one of the most competitive matches this year, that every spot was filled. So maybe that's also speaking to people knowing that we're gonna need some of that help down the road.
That's amazing. You know, Erin, in terms of long term from coronavirus and so forth, one of the things I do worry about is people smoke cigarettes to self-medicate for their emotional or mental disorders. People drink to self-medicate for their emotional or mental disorders. Dr. DeBruyn, pardon me for coming in on your turf just a little bit. I worry more about the medical consequences of smoking and drinking in the long term as a result of the pandemic.
It's interesting to me that in the newspapers and when you talk to people that you know, from the amount of work that doctors have had to do and how dangerous the work is that doctors and nurses do, you'd think that this would be a deterrent, but apparently people really want to be helpful to the world because these very hard times of this year have increased medical school demand to be a doctor and a nurse. So, it's not just an easy life that people are choosing. They're choosing a hard life.
And Emmett, the world needs more health economists too, right? No, but so, I mean, I think these are really important points. And Wendy, I'm curious, as you've probably been one of the people being paying most attention to the public and our changing kind of fears and perceptions and concerns over the last year. And I'm curious, just in general, what are the things that you've learned from that survey and anything that you can provide to kind of inform the panel here today too?
Yeah, so one of the things that we've been tracking is mental health, and it was especially in the beginning of the pandemic for most groups, mental health was not doing so well. Since then, a lot of people have rebounded, but some have not, and so this pandemic is especially hard for younger people. I mean, this is a time of their lives where they're supposed to go out and party and hang out with their friends, and that's not happening, and it's difficult to be stuck at home with your parents. It wouldn't have been a good time of my life to be in a pandemic. Not that it's a good time anytime. And then, families with young children, especially mothers, are having a tough time because they're disproportionately taking care of the childcare of the children being at home. And, people have lost their jobs, and those are the people who are having the hardest time with the pandemic. And like Otis said, there's people are struggling and dealing with that by smoking more, drinking more, but also binge eating more. And so there are going to be health effects of this pandemic beyond just COVID infections.
Yeah, the other thing that I'm very concerned about are disparities in healthcare. People who don't do well in our healthcare system tend not to do well in our healthcare system. And what I'm saying is that, the folks who are poor, the traditionally underserved, they're going to be elbowed out and displaced as our healthcare system comes back into place. The people who are not going to get their mammogram for the second year in a row are the people who have Medicaid or the people who don't have insurance. The people who will get their mammogram this year and just miss 1 year are the folks who are middle class and upper middle class and well connected. And I could use that example talking about a number of different things in screening, but also in treatment of real disease, people who have real problems. The folks who have money are the ones who are going to get access to our medical system. The folks who don't have money are the folks who are not going to get access, even though they have a problem and truly deserve health care.
I absolutely agree. We've certainly seen this, in the realm of cardiovascular disease, that there's in something that I think the pandemic we've known, but the pandemic has really shined a light on, but particularly in cardiovascular disease, the disparities from socioeconomic class, minorities, has really, demonstrated that patients just do not get the same care. They do not get better care. And I think it's going to be so important from a public health standpoint to really make efforts for us to be reaching out to those communities, getting those communities to come back into the hospital, because that's step one, and then making sure that their needs are prioritized so that we're not dealing with, a spiral of poor care that leads to poor health, that leads to higher costs, that leads to poor lifestyle down the road.
Yeah, absolutely. Well, it's been a fascinating discussion. Thank you all. I want to give you a chance to give some closing comments or thoughts. So perhaps we can start with Otis. Give you all a chance to discuss kind of what you think is the biggest change you see in terms of COVID's impact on the healthcare delivery system, and what's likely here to stay as we look forward and look ahead.
Well, thank you. I'll start out by saying everybody who can get a coronavirus vaccine, please get vaccinated. I'm also very concerned about variants out there, and I'm concerned that the coronavirus epidemic is not going to be over at the end of the year or even the end of next year. Going back to the pandemic from 1918, there were cases seen in 1927 and 1928. So this thing may take a while to peter out over time. Now, I think we really desperately need to worry about how we can get adequate care to every human being. We need to realize there are a group of people who are prone to disparities because they don't get adequate care. We've talked a lot about treatment here, although we did start wandering into another area that we should talk about, and that is prevention or risk reduction. Things like bad diet and lack of exercise cause cancer as well as cardiovascular disease, I should point out. Alcohol abuse causes a number of different diseases to include cancer. So I think we need to worry about those sorts of things, as well as worry about how our healthcare system gets people good, adequate health care. Now, the one thing that in economics that I do know about in terms of healthcare is we spend 18 to 19% of our gross domestic product on healthcare. That means for every dollar spent, about 18 or 19 cents is spent on healthcare. In countries that we compare ourselves to, the equivalent is 10 or 11 cents. Unfortunately, for most diseases, Western Europe and Canada have better outcomes than we do in the United States. So we're already talking about a system that's bloated, too expensive, and has a lot of problems in providing quality care, and has a lot of inequities in how it provides that care. And now the system is wounded because of the coronavirus epidemic for the past year. I don't have all the answers to the problem, but I think all of us need to realize that there's a problem there. Thank you, Erin.
Absolutely. Thank you. Wendy, can I turn to you to kind of wrap up your concluding thoughts on what you think the pandemic means for patients and individuals moving forward?
Yeah, so I'm not quite ready to start thinking about the return to regular healthcare. My mind is still on the vaccine rollout and how do we reach the communities that are currently not disproportionately less getting vaccinated because of the barriers that are in place. So we need to make it easier for people to get vaccinated by bringing the vaccination sites to their communities during times that they're not at work, and so that it's easier for everyone to get vaccinated.
So Emmett, as a patient, do you think that these changes that you went through over the last year are here to stay, or do you see return to the ways of old in the future? And one more time, you're on mute.
As a patient, I think things will come back to normal. There'll be the long run implications that people have been talking about, but the patient experience, I think, will be similar. Maybe for people who need telemedicine, that'll go on. I just have to say, as a researcher, so I'm on research projects that have been trying to gather data over time. The year 2020 will always have like a little flag associated with it. So you'll say, this is what happened, and we're going to either ignore 2020 or somehow find a clever way to make use of 2020. It's just going to be very important to researchers that are interested in the trends of things over time to make the appropriate adjustments for this amazing thing that's had just such an impact on all kinds of society. But as a patient, I don't, for me anyway, I don't see any much change starting now.
Fascinating. Yeah, absolutely. Lots of we'll be having webinars from the research perspective, I'm sure, for years to come. So, Suzanne, we'll give you the last word in terms of your thoughts on changes in the future of healthcare delivery.
Sure. I mean, I think, to echo what Otis said, we spend a lot of money on healthcare in the U.S. And we don't necessarily have the world's best outcomes, which you wouldn't think those two would go together. I think what the COVID pandemic at least showed us is that we can adapt pretty quickly and find new ways to administer healthcare to patients. And so I kind of hope that we, as a medical community, as also as a public health community, take some of the lessons that we've learned about adapting and finding new ways and new programs and ways to reach patients, and can kind of take that going forward to address some of these poor outcomes, some of the disparities in care that are there. In particular, I want to echo what Otis said as well with regards to prevention, because from a cardiovascular standpoint, that's absolutely huge. Healthy diet, exercising regularly, not smoking, getting your cholesterol checked regularly, getting your blood pressure checked regularly, doing those sorts of things, which are, very basic standard things, are not things that every patient has access to, or that even, in the best of scenarios. And so I'm hoping that with the advent of telehealth, that we can maybe as a medical community be more aggressive about bringing forth preventative care and healthcare education to patients who may or may not have had access to that before.
Fascinating. Well, thank you all so much for joining us. It's been a fantastic panel and super interesting conversation. Thank you to our audience for joining us, and remind you or invite you that we hope you'll join tomorrow as we continue the conversation, focusing tomorrow on whether the US healthcare system is ready to equitably meet the demands of this new kind of patient-centered care model, and as we think about the evolution moving forward. So thank you all so much, and have a lovely afternoon.